Audio recording for this meeting has begun.
Good afternoon, and thank you for joining us for the second installment of Et al., the NCSD Journal Club. My name is Leandra Lacey, and I'm the Capacity Building Manager for NCSD, the National Coalition of STD Directors. My hope is that this Journal Club will not only help to keep you abreast of current STD literature, but also that you can use the findings from articles presented and apply them to your own STD program. This is just a reminder that this webinar is being recorded and that the recording will be made available within 1 week of this presentation. If you have questions during this call, please utilize the chat function in the bottom right corner of your screen. Also, just a reminder to put your phone on mute as well. And there will be an opportunity at the end to unmute lines for questions. If you need technical assistance during this call, please also utilize the chat function. You can private message my colleague, Neil Rana, who's listed as a host. And he also has his email listed in the chat box on the bottom right-hand side. All questions for presenters will be addressed at the end, but we'll keep a queue, so please send them our way as they come up. I also want to flag for you that there's a box called Files on your screen. And in this box, you'll find the journal article that is presented today in case you need to download it and reference it. And as I previously mentioned, the purpose of this journal club is to not only help keep you abreast of current STD research and literature, but through engaging discussion with each other and with the presenters, you'll learn about the implications of this literature on the STD program in your jurisdiction. And articles chosen will vary depending on emerging issues in the field. Each month following the webinar, a blog post will be shared via the NCSD STD weekly email, which I hope all of you are subscribed to, and on the NCSD website, where an author or authors of the previous month's article will answer a few questions regarding the article's implications for current STD programs and practice and other related areas they feel need to be further researched or explored. So for our agenda for today's webinar, we will start with an introduction of our presenters. We'll then move into the article background, methods, and results, followed by a time for discussion and engagement with the presenters and with you all, the participants. There will also be ample time for questions for the presenters at the end, which I've previously mentioned before. And feel free to use that chat box on the bottom right-hand side. And as a result of this webinar, you'll be able to describe the major sections of the journal article that is presented, like the background, methods, and results. You'll also be able to identify the article's implications for your state's STD program. So without further ado, I'll let our presenters today, Sydney Minnerly and Karen Sarita, take the floor. Sydney is the Partner Services Coordinator, and Karen is the Data to Care Coordinator at the Texas Department of State Health Services.
Okay. So good afternoon or good morning, everyone. My name is Karen Sarita, and again, I am the Data to Care Coordinator at the state of Texas. So today, Sydney Minnerly and myself will be discussing a paper that was published earlier this year in the Sexually Transmitted Disease Journal, and it was on the differences in partner services outcomes for men who have sex with men with a diagnosis of primary and secondary syphilis by HIV serostatus. So just to give you a bit of background about Texas, we are a decentralized health system in Texas. We have 18 local and regional health departments. 10 of these health departments are local health departments, and they do cover our larger cities and medium-sized cities in Texas, while our 8 regional health departments cover a vast majority of regional health department, regional areas that cover several counties, as you can see in this map. We have a workforce that is comprised of about 100 DIS at any given time, and our HIV and STI services are integrated. In 2016, to give you a picture or an idea of the number of cases that we followed up with in Texas, we had about 9,000 assigned syphilis interviews, and 8,000 of those were interviewed. Around 8,000 were interviewed by our disease intervention specialists, and that includes all stages of syphilis. When we look a little closer at early syphilis, 4,755 were assigned to our DIS, and they interviewed 4,218 of those cases, early syphilis cases. For HIV, we had 4,000 assigned to them, and our DIS interviewed 3,410. So when we look at cases that had comorbidity assigned, 53% of those had a comorbid infection or a co-infection, and those are what we consider our big five. So those are our 5 of our larger cities in Texas. And it's harder to capture that due to DIS. They may not enter the second disease in our system, in our STD-MIS system. So the burden of disease that exists in the Texas MSM community actually increased from 226 to 432 per 100,000 for the years 2010 to 2016. And this early syphilis burden for MSM who are living with HIV was an estimated rate of disease for 1,878 per 100,000, and this is over 4 times greater for the overall MSM population, but actually 6 times higher for HIV negative MSM living in Texas. Let me get used to that. So we decided that we wanted to analyze the data, and DIS in Texas collect a large amount of information during their interviews, and we enter it into an older system, STD-MIS. Actually, throughout the years, local use fields have been created to capture information that we believe may be of benefit for programmatic use. We needed to determine our current partner services outcomes and assess program efficiencies. This analysis also helps to provide an opportunity to recommend changes to policies and procedures in the field. Okay, so we had many questions from our programs. We would hear from them that they can't meet their objectives. We would hear that their partner indices are dropping. And we wanted to know, both at the DSHS Central Office, where Sydney and I work, along with a few other counterparts, and our programmatic staff, what can we do? So we had so many questions, like I've said so many times, but we noticed that there was a sustained decrease in partner indices across the state in all jurisdictions. So we heard that from the program, and we also noticed that we did see that across the board. Many of our programs attributed this to partner selection sites such as internet, hookups, and applications. But we also know that anonymous partner selection venues have always been a part of partner services interventions. And sites were also stating, so our 18 sites were stating that someone's HIV status may actually influence their cooperation with the DIS. And so our other questions were, how does this previous exposure to partner services influence the outcomes? So we decided that we wanted to look a little bit closer at the data, and this is the basis of what our paper, or how we started our paper. So we took a look at data from STD-MIS, and we analyzed it from the years January 1, 2013 through the end of December, so December 31st, 2016. And we looked at those interviews that had a primary, secondary, and early latent syphilis diagnosis in males who were over the age of 13. And they were initiated for partner services. Then we took a further in-depth look at the number of persons who were diagnosed and received an interview of partner services. So someone who was interviewed, they had to have completed the interview, so agreed to the interview and completed it. We excluded persons who refused the interview, were unable to locate, or had another documented reason, and that was a smaller percentage. And then we took that number of persons who were diagnosed and interviewed by Partner Services. We looked specifically at individuals who had a risk who were male, and or during the had named male sexual partners during the infection period, or were self-identified as gay or bisexual. And then finally, we looked also, if they didn't have that self-identification, we looked to see if they had a reported risk in EHARS or STD-MIS. And that gave us our 9,415 number. Then we looked further at someone's HIV serostatus. So we looked to see if someone was negative and had a risk factor of MSM, and then also looked to see if the person was HIV positive and had a risk factor of MSM. So for persons who had an HIV diagnosis in at least 30 days prior to their syphilis diagnosis, we considered them to be HIV positive. And then the reason we excluded the concurrence of HIV diagnosis was because we assumed that their HIV diagnosis would not have influenced their Partner Services outcome. And we looked at these two groups a little bit closely. We looked at some characteristics of their interview. We looked at the age that they were diagnosed with syphilis. We looked at their race, the stage of syphilis diagnosis, and then we also looked to see if they had a reported use of geospatial applications such as Grindr, Jacked, Growler, and Scruff. And then we looked at the number of times the person was involved in Partner Services, and then we looked at to see if they had prior no partners initiated. So they didn't name anyone during their interview. And our initial outcomes gave us the following information. 66% of these cases not interviewed, were males who were HIV positive. Of course, in the cases not interviewed are what we would consider someone refused the interview, they were unable to locate, or it was not specified, and that's, again, a small percentage. And then 80% of MSM who were HIV positive were previously initiated for interview for HIV or a previous STI. And this was only looking at the data that we had available from in Texas. Again, 48% of this 80% were named as a sex partner during an interview, and then 46% of this 80% had at least one no partners initiated during their interview. Okay, and then when we look at the proportion of interviews, early syphilis interviews with NPI interviews by the year, from the years 2013 to 2016, there was a generalized increase in NPI interviews for MSM from 2013 to through 2016. And this trend was significant for both HIV positive and negative MSM. More than 40% of the interviews for HIV positive MSM were NPI, or no partners initiated, compared to the lower percentage in HIV negative MSM. We did a further comparison that's not on this graph here, but in the paper, where we looked, we compared the actual outcomes for MSM interviewed by Partner Services, and HIV negative MSM named more partners compared to HIV positive MSM, and then all Partner Services outcomes were significantly higher for MSM who were HIV negative than those who were positive. And Sydney, I'll pass it on to you.
Thank you. So as part of our discussion, we noticed that the previous no partners initiated was actually a stronger predictor than their HIV serostatus for future NPIs. Partner Services elicited fewer partners. Named partners were less likely to receive treatment and testing, and were also indicated to more likely result in the NPI. One of the considerations that we have is, how does Partner Services for a person who has a previous NPI, how does that influence the DIS's attitude? Does the DIS look to see that this person was an NPI in previous investigations? And due to an overburden of workload for the DIS due to staffing shortages and turnover, are the DIS more willing to take shortcuts or rush an interview that they expect will not be productive? Is there a training that's necessary for developing those DIS and allowing them to more robustly review and work with those persons who are not, who had previous NPIs? People generally who were previously initiated as a partner on a case were more likely to participate and provide information on their partners if they were indeed a partner on a case prior. So that lends itself to an assumption that there might be some identified value in my previous experience. I saw that my partner named me, and I saw how the investigation was carried out, and I have a higher confidence rating for those services that are provided, and I know that my identification and my confidentiality will be maintained. We also noticed that the geospatial users, the folks that were using apps and internet meeting sites, were more likely to have a higher partner indices. And they were also, they were not likely to have as many NPIs. Sorry, trying to advance the slides. Karen, can you advance the slides for me, please? Thank you. So future activities that we came across from the study is that we are going to work with our DIS and public health follow-up programs to advocate for new alternative ways of performing interviews. One of the ones that we have already implemented is telephone interviews, but we also want to explore the possibility of utilizing web-based interviews such as FaceTime or other web interactions. Additionally, we want to explore with patients through patient surveys and interactions on whether or not self-referral and internet-based surveys or interviews would be something that would be appealing to them, especially for those who have already been through the process of an interview. We also want to implement methods for DIS to electronically document marginals. So one of the issues that we've noticed is that folks say that a person had 15 partners, one person was initiated, the rest are marginals, and we don't have any way of tracking how robustly the DIS are exploring those marginals. So for example, if the DIS says, how would you get in contact with this person, what's their phone number, and the person says, I don't have their phone number, are the DIS more likely to call them a marginal, or would they be more likely to explore other opportunities for contacting that individual? And in addition, for electronic documentation of marginals, we are developing a method for them to promote those marginals to actual partners or sociosexual network contacts if they do indeed find additional information from a re-interview or further contacts with the original patient. We're also providing the DIS with an opportunity to actually document the specifics of the partner selection venues that they're utilizing. Currently in STD-MIS, they just have a risk factor that's identified as sex through phone app or sex through internet, but we don't really have a really good way of documenting aside from within notes, which makes it very difficult to track. So we're going to allow for the DIS to document specifically which apps are being utilized so that we can track those and develop frequencies on how those apps are being utilized. And again, as I said, with the ability to initiate marginals electronically, it will provide us insight on how the DIS are utilizing their skill sets and getting more information to help differentiate between a person who is truly one who is not interested in providing or cannot provide information on their partners versus somebody who just does not have the information on how to contact their partners. Next slide.
Oh, I went to.
So we still don't know what is really truly driving the decrease in partner services or partner indices overall. And so that's a question that we will want to explore at another time. So I see that we have some questions. Leandra, do you want to?
Sure, yes. Thank you, Sydney and Karen, for this great presentation on the article. So first, Anissa Davis had a question, just to get some clarification. Those who used apps didn't have as many NPIs, or no partner initiated. That goes against our accepted thought that app partners are more difficult to initiate, correct? Could you do a clarification of that for her?
Mm-hmm. Sure. So yes, that is correct. So when we used, we looked at several characteristics of the interview and outcomes, and geospatial interviews or apps were one of the things. So when we looked at that, it was not significant enough to say that it was more significant to say that persons who were part of the interview process, who were newer to the interview process, were able to give us more information than just looking at when we did a comparison of all the characteristics, or more characteristics, sorry. Sydney, do you want to jump in and maybe?
Yeah, so basically it's just not necessarily significant. So so the partners, or so somebody that identifies the geospatial app as one of their risk factors, if you want to call it, we're not any more or less likely to have NPIs. It was more based on their experience or their previous experience with NPIs and not providing the data or information. So that the app didn't seem to influence whether or not it was going to be an NPI. Does that make sense?
Thank you. And Anissa, if you have any follow-up questions to that, feel free to type them into the chat box as well, and we can address that. So you, Sydney and Karen, you also use the term marginal contact/partners, and Daniel Davidson wants to know, can you define what that meant for you all?
Yeah, so when we have DIS who are conducting their interviews with persons who've been identified with an infection, they will go in and attempt to find information or elicit information about the partners. And there are partners who they only know a screen name for, or they only know very limited information about that individual. And so that information, while important to the investigation, may not lead to actual initiation of that individual. And so we call those persons marginals. It is strongly recommended or encouraged for DIS to revisit with the original patient in further instances or further conversations to try to find out more information about that individual so that they can locate them. So usually in Texas, we operate off of the premise of having at least two points of contact. So a first name and a phone number would be enough to initiate that person. A screen name would be enough information, hopefully a first name. It's a little bit trickier with internet applications as well as the phone apps, since especially with the phone apps, people are changing their profile names routinely. So it does make it a little bit more difficult to reach. But we just generally, if a person has a first name and an address or has some descriptor and an address, we would encourage DIS to go ahead and initiate that individual. But a marginal is somebody that you can't really do any follow-up on, but you may want to keep track of so that you can revisit that in future conversations.
Awesome. Thank you. And Daniel, if you have any follow-up to that, feel free to type it into the chat box. It looks like you did clarify for Anissa, so that's great. I'll move on to just some other questions to think about for all of those who are participating today, and also for our presenters, just to get some engagement going on. So, this article is something that I'm sure can be applied to other jurisdictions, and I'm sure other jurisdictions are seeing similar trends in decreasing, partner indices. But I want to pose for the group, have you noticed a similar trend that, as Karen and Sydney were talking about, of decreasing partner indices, specifically for MSM in your jurisdiction based on HIV serostatus? And if so, what strategies has your program employed in order to address that issue? So feel free to use your phone line, or you can type into the chat box as well. Or if you have other questions for the presenters, you can continue to put those in the chat box as well. We'll give folks a minute to get responses together. And Sydney and Karen, if you have anything else to pose in the meantime, feel free to shout those out too.
One of the questions that we have also is, so if a person is previously diagnosed as HIV positive, I mean, this was kind of one of our original questions because the sites were asking, if somebody was previously diagnosed as HIV positive, does that truly lend itself to a less productive interview? And just curious if other sites have had that question or had that concern brought up to them and how they are addressing it. And I'm not sure what roles people have who are on this call, so that if there's any DIS who are actively working in the field, if they have any stories or any qualitative data or information they want to share, that would be interesting. I mean, one of the things, like I said, we're trying to do, at least with our new database system, is that we're interested in finding out if people are really truly like refusing to provide partner information. For example, I'll go through the interview process, but I'm not going to tell you anything about my partners. Or is it more along the lines of, I really don't know how to contact my partners. This is as much as I can give you. And if it's the second scenario, is it just, is there room for training the DIS into enhancing their skill sets to make them more adept at exploring things such as where did you all have sex, where did y'all meet, you know, really exploring the needs for DIS training to actually enhance their interviews.
And that's definitely a good point. I'm looking at the second small bullet point under these questions, asking how DIS have adapted to these changes, you know, looking into interview techniques, how have those changed in response to the trends that folks are seeing. And I know in chats that we've had, Karen and Sydney, you were saying that, you know, it's worth looking at how DIS are interviewing and looking into the particular questions that they're asking and how they're asking them, because it could point to, like you said, a place for training as far as how to probe, you know, are they asking the right questions in the right way to get partner contacts. So it's definitely something worth exploring, and I wonder if other programs have looked into that as well, you know, actually assessing the questions that DIS are asking.
We also, in Texas, we also decided, well, we looked at the data, of course, and analyzed it. And our procedures and protocols prior to the rollout in 2017 were to DIS were not allowed to do telephone interviews only if they had they were not able to locate the individual after several attempts, and they did receive approval from their supervisor to follow up with a telephone interview for someone who had tested positive for syphilis, and only syphilis. So around the same time we were doing, like in 2016, we were looking at some data, and we looked at how DIS were spending their time and where they were spending their activities, and we made a decision that we would allow DIS to conduct telephone interviews. And this was important, especially for our, like I said, some of our DIS do cover large areas, which I know is in similar states have the similar issue. So we allowed them to do telephone interviews, and we found that we were successful with at least contacting an individual, and if the individual decided that they would move forward with the interview, we were productive in that way. So we did change we allowed programs to really utilize telephone interviews as a first line if the individual was willing to move forward, and we found success in that way as well. And so in some of our rural programs, a DIS might have to drive maybe 3 hours to locate an individual, and if that person is not there, then they've lost the ability. Then we don't want it to be necessarily a waste of time, but if the individual sometimes people don't answer the door, or they're not there, they're working, and so it gave them the ability to still conduct that interview over the telephone.
And this is kind of getting back to Anissa's question about persons who access the geospatial apps. While they were not significantly, it didn't lend any significance to the NPIs. They did have a higher partner indices, and that may be. We don't know what that's attributed to. There's been research on what the characteristics of those persons or individuals, what their behaviors are, and that sort of thing. And some have shown that the persons who are using the apps are more likely to get information about their partners, and some assume or think that maybe those people have more partners, but they don't. It has not necessarily been proven that they have more sexual partners. They may have more online interactions, but they don't necessarily have a higher number of partners, just depending on the individual. And it'd be interesting to see when we are able to get the documentation of which venues persons are selecting to meet their partners, if there's a way that we can construct a relationship with that venue to provide education outreach without overburdening and causing HIV, STD, or STI fatigue and within those venues.
That's an excellent point, looking into how to document partner selection venues, and I like what you said about actually forming partnerships with those particular venues, and looking at how to, better improve services through those partnerships. I think that's a really great point. And I also wonder if other folks have done any work with that, with forming those partnerships, and if they do have any partnerships, how they strengthen those and really maintain those partnerships. I think that's a good point of discussion as well. And one other point about the slides, they're actually posted under files now, thanks to Neil. Thanks for that question, Christy. Hopefully you can access it there. And we'll also send out the slides too after the conclusion of the webinar within a week. But yeah, I think looking into partner selection venues is super important, as you've all mentioned. So I'm wondering what work has been done in that arena as well.
Have any, again, like I'm not sure who the formal audience is, but I'm curious if any other jurisdictions have attempted to employ preventative treatment for persons who've been identified as part of the network within the partner selection venues. Since there is some difficulty because there's not a physical place to go necessarily to do outreach or testing or education, that sort of thing, which is what has traditionally been done. But are other sites implementing or offering preventative treatment for folks who are not necessarily known to be named on the case, but are potentially involved within the sociosexual network because of their involvement within that venue?
Just to note that if you want to speak on the phone line as well in response, you can do that too, in addition to typing in the chat box, if that's easier. I know it can be a little bit faster, but don't be shy, you all. Either way works.
I know that when we've noticed increases in morbidity within populations, we have encouraged programs to explore that as an option, specifically because of, like I said, there's no physical place to offer our prevention services. And so when we've noticed an outbreak or an increase in morbidity, specifically within the MSM population, some of our sites have explored that as an option of addressing. And it's an opt-out. I mean, it's an opt-in. The clinician presents it as an opportunity for them to prevent incubating disease or potentially incubating disease. And then the individual is able to make that decision on whether or not they want to receive that treatment.
Sydney, do you know what the uptake has been like with that?
You know, I haven't actually asked them in a long time. I don't remember. It was not insignificant. There were men who were interested in receiving that treatment, but I can't give you a number. That could be something that we could explore with our sites to see if they're still implementing those. But it was, you know, I was surprised at the number of people that were accepting the treatment, and it also depends on how it's presented to the patient, of course, and how robustly one provider promotes it versus how another within that same clinic may poo-poo it or may not feel as invested in it. So I'll have to ask, I'm thinking of one site in particular, I'll have to ask them if they've continued to do that and or whether or not they found any significant uptake on that. But I do feel like it was surprising.
Okay, thank you. Any other questions or even comments as well for our presenters? What about in jurisdictions where partner indices may be a little bit higher? We've talked about this trend of decreasing partner indices, but are there any folks on the line who may have information into partner indices in their jurisdiction? Do you know if it's high, and if so, why do you think that is? What strategies are you all employing to keep it at that level? I feel like we always kind of hear the opposite side of that, where things are decreasing. We hear that more often, I should say. But what about where things are high? Why do you think that is, if you're experiencing that? And Sydney and Karen, if you know of maybe colleagues in other jurisdictions where they do have high partner indices, do you know what tactics they're using or what programs they've initiated for that? You can speak to that as well if you'd like, if you know of any. Or it may be that all your colleagues are experiencing the same thing. So that's also another thing. And if you know of folks who are experiencing the same thing, do you know of the challenges that are specific to the jurisdiction that they are trying to overcome? And are they similar to things that you all are experiencing in Texas?
I don't know of any jurisdictions that have really high contact indices or higher contact indices, or have not seen a decrease in their contact. I know that some of our jurisdictions are reporting issues because of the immigration debate that's going on right now, with people not available to provide information or interested in providing information for fear of their immigration status being questioned, and or don't want to initiate persons who may be at risk of being deported from the states. So I know that there's been some anecdotal reports from sites that persons may be less willing to provide that information for fear of a government entity or agency approaching that individual, and that individual not actually getting the benefit of the services because of fear of retribution for their status.
Thank you for that. We also have a comment from Portia King. It's not showing up in the chat where everyone can see it for some reason, but it's showing up in a separate chat for presenters, but I can read it aloud for everyone. Portia says, I'm in FLS in Oklahoma. We definitely are having the same issues, but unfortunately, I have no insight into making these entities more successful. It has been a true struggle. We get a combination of anonymous partner stories, mainly Grindr, and a healthy amount of positives who will do the entire interview and just refuse the partner services part. The latter individuals tell us that they will tell their partners themselves. We ask them to pass along our information so they can contact us if they need our services, and we have had some success stories with that in terms of co-infections with historical 900. We have been able to get more honest answers regarding partners after making sure they know that we are not there to criminalize their behavior, only to assist in the spread of the disease. Thank you for that, Portia. I appreciate that comment. And I think, you know, when you talk about emphasizing that you're not there to criminalize their behavior and only to help is really important. And I think it speaks to interview techniques for DIS. It speaks to their skill set and how they are interacting with clients. So I think that says a lot. Like, how do DIS come off in the field? What do clients really think of DIS when they're approached? Sydney and Karen, I don't know if you want to add to that as well, but I'm sure that is not an uncommon thing at all. So Portia, thanks for that comment.
That's definitely an issue. I mean, go ahead, Karen.
No, I was going to say that's one of the reported, one of the things that I wanted to say before your comment, Portia, but I think, I mean, I appreciate it because I think it speaks to that, as well as in Texas, we do experience a high turnover in some of our staff and some of our programs. And so I feel like before that we were experiencing very high turnover, you had people who were there and could mentor new staff. Some of our programs where they've implemented more of a collaboration with having these team meetings or team huddles where they strictly focus on cases that may be challenging. We have, both Sydney and I and some other coworkers have really been able to experience that with them and just kind of not provide guidance, but really observe those interactions. And for those programs, I've seen them to be more successful with their cases when they have this collaborative measure where they're trying to learn from each other on what techniques are useful for them, so then they share with newer staff or staff who just maybe, like we talked about, have some marginal or some hard cases where the person isn't necessarily giving up or providing a lot of information on the person. They may change interviewers, and so based on that collaboration or meeting where they've talked about the case, they've been able to actually really talk to the person about the importance or hit home with some of the messages of why it's important to provide that information, how it's useful to help in just the larger picture.
And then also, one of the issues that we've had in Texas is kind of this antiquated recalcitrant rule that we had employed for a long time. And in spite of us trying to encourage programs to have healthy conversations about we're not here to criminalize you and that sort of thing, some jurisdictions have actually taken it to that level. You are HIV positive and you're not disclosing your status, and instead of actually being compassionate, have actually utilized that recalcitrant policy or rule to attempt to scare people into different behaviors. Sorry, I'm working from home and my dog is going to start barking now. So that's definitely a downfall that we've had. And we've tried to work with programs to understand that we are not here, as Portia mentioned, not here to criminalize, and we're not here to do anything. And as we all know, a lot of prevention methods and techniques have changed since the implementation of that policy or rule, such as the undetectable viral load and as well as PrEP and that sort of thing.
Thank you. It's funny that you mentioned the undetectable equals untransmittable. Some talks that we've had here at NCSD is what that means for STDs and for the field at large, and what implication it has for that. So it was just funny that you brought that up, Sydney. So yeah, thank you for the response to Portia. And we'll take any other questions as well for Karen or for Sydney. Any other comments? This has been a great discussion, so I really appreciate the engagement for sure. Okay. If we don't have, oh, well, see, Portia's typing again. I'll give it a second.
Is it easier if I just talk?
Sure. Feel free.
Okay. I was just going to go back to where you're talking about implementing different interview strategies, and you were looking into doing telephone interviews. That's something that has come up here several times, but we kind of keep hitting this wall of people not feeling like that's a secure way to speak to individuals, especially individuals who are HIV positive. Is there research? Are there things that you're using to try to help convince your program to use that approach or consider that approach?
So in 2017, we did a pilot with some of our jurisdictions. We kind of tried to like Karen mentioned, we have a variety of types of programs, such as rural programs or large metropolitan areas or smaller cities. And we had them do a pilot on the efficiencies of telephone interviews because we had people who are very interested in continuing the face-to-face. And it's not that we want to discourage face-to-face, we just also want people to have other tools available to them, especially when it is somebody who's difficult to reach and or, you know, can't take the hour out of time to do the interview from work, but is willing to participate in the process. And so upon that completion of that study, we found telephone interviews to actually be more efficient and more effective. And since we've implemented it statewide, there's, I think, correct me if I'm wrong, Karen, relatively insignificant differences between those.
No.
And also in the state of Texas, we're not allowed to do initial interviews for persons who are HIV positive because we don't know if they fully understand or know their status. So the only ones that we are allowing currently programs to do phone interviews, and that of course is in air quotes because we know people do them anyway. We only have so much control over that, but the only ones that they're allowed to do would be the bacterial infection. So it would be the the syphilis or the gonorrhea, chlamydia if they happen to be doing that interview, and or if they know that that person knows their HIV status. But at no point should the DIS disclose that person's HIV status over the phone.
We also learned, so when we did when we were doing the pilot project with 5 of our sites, we did a qualitative interview to receive feedback from the DIS who were conducting those telephone interviews. And we did hear, because we did hear from programs as well, how are we going to ensure that this is the person that we're really trying to reach? So we used the same types of, when a DIS will call a person, making sure that we have the right individual by asking some identifying questions. If we have a physical description, confirming that. So using those same techniques is what we did. But we also heard from our DIS that tone was very important during the telephone interviews, and making sure that DIS were able to really take the time to listen to the individual and to pay attention to their tone. And if any time that person, the individual we were interviewing, felt uncomfortable, then we could stop. Then we made sure that they knew that they could stop the interview and just meet the person face to face to have that level of comfort. And then also, if the DIS felt that this was not the individual they were really speaking to, then they again would stop the interview. And really throughout the interview, we heard from the DIS that they had to continue to reiterate the fact that this was a confidential interview, and reiterate the things that that it's in the benefit to move forward with it. That it's in their benefit to provide information, and that it would be confidential. And then they would even use some scenarios or situations that they would use in the field, but they felt that they really needed to hone in on the tone of the individual and take their time and listen for it to be a successful interview.
Yeah, I think that's one of the things that we found with DIS who are more successful with the telephone interviews is that they actually took the time to work with the individual and, like Karen said, listen to their tone and really revisit with them if they got any sense that this individual was starting to feel uncomfortable with the process. It's a lot easier to do if you see body language and you can see that the person's getting agitated or fed up. But with the phone interview, you really had to take your time in making sure that the individual understood the purpose of the interview and the process. And some of the patients, especially ones who had already been through partner services processes, were more likely to participate because they understood the role of partner services. They'd been through it before, and they were more willing to just disclose partner information for that aspect of things. So those were the folks who were, and that's why we're thinking whether or not partner services, for folks who have already been exposed to it or have already had previous interviews, would it be more beneficial for them to have the offer of a phone interview so that they can, go about, we all have daily lives. We don't want to make doctor's appointments that we don't have to. And, we can schedule a time to meet for 30 minutes on the phone as opposed to you having to drive, the DIS having to drive out and or me having to drive down to the clinic.
All good points. Thank you so much for that. We can take any other lingering questions or comments. We have about 3 minutes. So if you have anything else for Sydney or Karen, feel free to unmute your line or put them in the chat box. I also have included on this slide Sydney and Karen's email addresses. The names are mixed up, but I'm sure you can tell who is who. Sorry about that.
I'm sorry, I didn't catch it.
No, it's okay. So their emails are there, my email as well, if you have any questions about the Journal Club. Yeah, so we'll take any last questions if you have them. I'll give it a second. Okay. So with that, I'd just like to say thank you all who have attended the second installment of Et Al, the NCSD Journal Club. A special thanks also to Karen and Sydney for their time and contribution to the webinar. As I mentioned before, I've included their contact information as well as mine, so feel free to reach out directly with any additional questions. And in the chat box, Neil has also included the link for a very brief webinar evaluation. So please complete it so that it can inform future Journal Club webinars. As previously mentioned as well, today's recording and slides will be sent to all of those who registered for the webinar within 1 week. So with that, I just want to say have a wonderful day and be on the lookout for the blog related to this article in September. It'll be posted in the STD Weekly and also on the NCSD website. And then the next Journal Club webinar will be in October, so be on the lookout for that as well. Thank you so much, everyone, and thanks again, Karen and Sydney.
Thank you, Leandra.
Yeah, no problem. Thank you. Have a good day.
Bye-bye.